people to our virtual board once again. And a particular welcome this morning to somebody who isn't quite a board member yet, but it's a pleasure to have, if you like, in the public gallery, and will be within the board next time, and that's Chris Lawrence. Chris, I don't intend to go through your CV. It will be publicised through the trust and others, but I know that you will bring a wealth of experience as somebody who has recently been a chair in the Eastern region and has a very extensive background, both in finance and business and wider than that. You will be a tremendous asset to the board. And sad as we will be to lose our current audit chair, it's a very great pleasure to welcome you in formally this month, and I will welcome you formally next month. So welcome, Chris.
Sheila, very quickly, thank you very much indeed for that. I'm really looking forward to it. My NHS background is in mental health and community delivery, so I'm really excited by the prospect of sort of getting engaged and involved and learning more about acute services. So really looking forward to it and delighted to be part of your number.
Thank you, Chris. I will say more about our departures at the end of the public board meeting. So we'll do the welcomes now and the departures later. If I may kick off, apologies for absence. I have Richard Davis, Richard Jones and Kate Thornton. Do I have any others, George?
Yes, Alan Rose.
Thank you. In which case, I'm going to move to declarations of interest. Do I have any declarations of interest other than the ones we normally record that roll from month to month? I will take that as no, thank you. Now, I'm going to crave the board's indulgence at this point. We have with us Dr. Francesca Crawley to do the Guardian of Safe Working annual report. She has got a clinic, and I think it's much more important she goes and sees patients than that we pull her out of a clinic to present her report. So I'm going to ask Francesca if she would mind going now so that we can release her for her clinic. But before I do, and good morning, Francesca, I think you have joined us.
Yes.
Good. I have a problem if you haven't. Thank you. Can I just, there's a couple of governor questions, and I wondered if you could answer these as you present your report. So if I might read them to you. One has asked, what is an exception report in the Guardian of Safe Working annual report? And the other question is, in the Guardian of Safe Working report, it states that surgery out of hours is an issue and very little concrete action is being taken. Is this problem understood, and has it been escalated to the appropriate level? So you might pick up that particular issue and just explain the exception report principle. Is that okay?
That's perfect. Thank you, Sheila.
Thank you. In which case, I'm going to hand over to you. Welcome to the board again.
Thank you.
And over to you for your report.
Okay, thank you very much for that lovely introduction, and thank you for being so accommodating. I don't have a clinic. I'm working for HE today, but I do have something else to do. So thank you. My name is Francesca Crawley. I'm a consultant neurologist at the Trust and Associate Dean for HE and the Guardian of Safe Working, which is a role I think I've probably had for about 2 years. So I think you've all seen my report. Basically, there are several things to summarise. One is to thank the Trust, because I think the juniors we've all had a terrible year, and the Trust have been very supportive, and equally the juniors have really stepped up to the mark. They haven't complained, they've risked their own health. They've worked in fairly appalling conditions, to be honest. You know, the space that they have to eat and drink has been awful, and they've just got on with it. A load of them have had COVID, they've had to self-isolate, but they have just got on with it. The other person I'd really like to thank is Helen Croon, who is the medical staffing manager, who really holds the show together. She has a WhatsApp group with 100 and something juniors on it, which I'm on too, and whenever they raise concerns about this, that and the other, Helen's like a mother. She just settles them all down. It might be 2 o'clock on Saturday afternoon, and she's like, don't worry about that at all, this is what we'll do on Monday, or here's the out of hours number for IT, just ring them and they'll sort it out. So honestly, I think the juniors would be a much more complaining bunch if they didn't have Helen, not at arm's length, literally right on top of them, helping them out. She is just, there's lots of helpful people, but I think that they found that WhatsApp group amazing. For example, people have said I have to self-isolate, and other people have just said, oh, let me go and do this for you, and Helen's put it all together. She doesn't do everything on it, but she holds the fort with it. So there we are. So exception reporting, yeah, she's one of our HL stars, that's it. If anyone doesn't know who she is, sorry, she's just so familiar to me. Exception reporting in 2016, the new junior doctors contract, which is when Jeremy Hunt was the whatever he was, and they were doing the junior doctors strike. The only, well, a good thing that came out of that was that juniors now should work the hours for which they're paid, because it's recognised that if people work for too long, we get tired. We don't do our best and patient safety is compromised. So exception reporting is if my shift is from 9 to 5 as a junior doctor and I stay till 7 because I'm looking after your husband, partner, whatever, I'm conveying information to you, someone's gone off on the ward, I'm helping. I don't want to hand that over to the out of hours team because they're too busy. I can put in for 2 hours of time off in lieu, which is what we prefer the juniors to have, and the rota coordinators are massively accommodating in giving time off in lieu, or we can pay them for that time. And those are most of exception reports. You can also put in exception reports for immediate safety concerns. I just don't feel safe, and you have to do a data. There's a whole process for that because it's quite a big thing to say I don't feel safe and I'm just going to fill in a form on Monday about it. It's just no, you have to do something about it now. You have to let somebody know now. So those ones are much more, there's a proper datix process. You have to let the site manager know, you have to let somebody know. And then there's one for mistraining opportunities, which goodness knows why people haven't filled in the pandemic, because the anaesthetists have been doing ITU, the surgeons, I don't know what they've been doing, but not surgery. I'm talking about the trainees, not the consultants, have been doing something that hasn't been surgery. They've missed shed loads of training opportunities, and they haven't filled in exception reports for that, but they could have done it. It's also if you miss going to teaching, which it happens. And it's just good for me to the Guardian to know that, you know, if a particular ward isn't releasing its trainees for teaching at foundation level or at core level, I could do something about it, probably just by ringing up the consultants and they're like, oh, we didn't know that. So there are 3 things to exception report. One is for time, one is for safety, and one is for missed opportunities. And 99.9% of the ERs that come in are for time rather than anything else. And as I say, we try to acknowledge that by giving them time off in lieu, because what we don't want is an exhausted work staff. And I think we've really learned that over the last 15 months, particularly. We've all realised the importance of you know, looking after each other. So that covers exception reports. And then the surgery issue. So I was the foundation programme director for 10 years and I stepped down from that role, I think about 3 years ago. I'm sorry, my timing is very bad. And when I was the foundation programme director, there was an issue with out of hours cover for surgery that I went to several meetings about and then handed it over to my successor. And then at the beginning of this year, there was a serious incident regarding a junior doctor on the ward. It was an F1. It was possibly September. They were brand new and they felt very unsafe. It was Datix Red, I think. It was fully investigated by the trust. I don't know the outcome of that, but the F1 emailed me to say, can I come talk to you? This wasn't safe. So she was supported, Then quite soon after that, he was an F2, put a couple of safety reports in for exception reporting. At least I think they were safety reports. I kind of assume they were, saying that the out of hours cover in surgery wasn't safe. So on the back of the 3 things in very quick succession, we restarted a meeting with the CD for surgery, the college tutor for surgery, various surgeons, I'm not sure, I'm afraid, what Simon Taylor's role is, but he's very senior manager in surgery. I don't exactly know what he's called, but anyway, senior surgical manager. Lots of sensible people around the table. We have probably met over the last 6, 7, 8 months. Sorry, 4, 5 times. There's lots of discussion, and I'm just anxious that it hasn't totally been resolved to anyone's satisfaction, I don't think, really. And at the moment it's fine because we've got a load of junior doctors who are in their last bit of the academic year. They know what they're doing. They're a bit braver than they are in August. They know how to work the system. They know how to, they just know how to work the system. Come August, they'll all be new again, or at least they'll be new to West Suffolk. They won't necessarily be new to training and to medicine. There'll be a whole load of overseas doctors who are new to the UK, and it is hopefully nothing will happen, but I'm not sure that we still have the safe provision out of hours to make it absolutely watertight. And I have put that in 3 reports to the board. My last 3 reports have mentioned it, and the surgeons know that I'm doing this. They said that will be helpful in increasing kind of, first of all, I said I'll report back when it's sorted, and it isn't sorted, so I'm reporting back again. That is possibly all I need to say.
Thank you very much indeed, Francesca. You wanted to come in, and I suspect it may be on the surgery issue.
It is, but also a little bit more widely first, if I may, Sheila. Thank you, Francesca. You do an amazing job as Guardian of Safe Working. It is sometimes a tightrope to walk. You're definitely independent, and you're definitely there for the junior staff. But I know that they, to them, you're still a consultant and you're a senior member of the parish, and I think you do an amazing job with Helen. So I absolutely second everything you say about Helen. But it's also down to you to get alongside them and to see things from their perspective, and I certainly am very grateful for that, and I know that colleagues are too. So thank you. And on the specifics, so I think it's important to hear, for the board to hear in public the challenges we've got in surgery. I know how hard you've been working, because you and I talk about this probably every time we meet, I should think. And I know that some changes have been made, and I also agree with you that I'm not sure we have made as many as we need to make yet. In fact, it's a shame Richard Davis isn't here, Sheila, because this has been discussed recently at very senior areas within the organisation. So I raised it at the Learning from Deaths group probably about 10 days ago, and the Division of Surgery raised it with the executive team at our PRM earlier this week. So it is definitely on everybody's radar. And as Francesca says, there have been a lot of meetings, and I share your concern, Francesca, that we have not necessarily got this watertight yet, which is why I brought it up at the Learning from Deaths group. There have been some really significant changes. So some things are definitely better on the light. So I chaired the serious incident review into the death that Francesca's talking about, that was at the very beginning of September, following the August bank holiday weekend. That was part of the problem. And we now have, for example, a sick list in surgery that identifies the patients that the surgical teams want and I kept on over the weekend, which is been stolen from medicine, which is how they look after their sickest patients out of hours, and we've put that in place in surgery. So that there have been changes. I wouldn't want anyone to think that nothing has happened, but I agree with Francesca. We need to make this. Whether you can ever make these safety things watertight, I'm not sure, but I think there is more that we can do.
Thank you, Nick.
Thank you, Nick. And if I could ask, I mean, it seems to me, I'm going back to the governor question. It sounds to me as if it's been appropriately escalated to the right level.
Definitely.
And some action has been taken. But I suppose, Nick, I'm going to look to you and to the executive team. How can we get some assurance there will be continued action? You're right. It may be impossible to get to 100%, but from what you're saying, we've only just begun to address this. So I'm kind of looking for some assurance that the work will be ongoing.
I'm sorry, I didn't mean to give the impression we've only just begun to address this. We began to address this years ago, as Francesca said. It has been slow. It is difficult. That's why there has been more and specific change in light of the death we had last August, September time. But there is, and Paul and I have discussed it, and Paul's idea is that we ask the Division of Surgery to bring forward a paper to execs, and that there will, through that, be measurable progress or not that the board can hear about from Paul. So I think that that's Paul's suggested way forward and seems very sensible to me. So I think it's good that it's here that we're having this discussion at the board, because it is now overtly on the board agenda. And therefore I know that our non-exec colleagues won't let it lie until they can be assured that there's been satisfactory progress. And I think that's right.
Thank you. And I can see nods from non-executives and from Paul. That's helpful. Thank you. I'll bring in Steve and then Francesca, back to you.
So I just want to thank Francesca for a great paper and reiterate what Nick said. You do a fantastic job, Francesca, alongside Helen and the team. So thank you. I really appreciate that. I think given the concerns, especially relate to the change of the doctor rota, I wonder whether we bring a paper back to the board before August, outlining what actions we're going to take to mitigate the risk in August. So, I'd like to see something ideally next month, certainly by the July board, so we're clear of what the position is for the August handover. So I'd just like to capture that as a discrete action.
Okay, thank you for that, Steve. Francesca, is there anything you'd like to add in the light of the discussion we've had so far?
No, but I'm happy to come to the board again. I mean, I am the vehicle of the conversation from the surgeons, and actually they've now said we're arranging too many meetings and then we keep cancelling them, so why don't we just give you the action points because we're wasting your time, which is very nice of them. But I'm happy to report back on their behalf because, I'm happy to do that. And the other thing to say is, just so you all know, the problem in medicine, there is a medical registrar who is on the shop floor 24/7. In surgery, they can't provide that. There isn't a surgical registrar who's resident just because of their training. There could be, but they'd have to sacrifice a lot of training opportunities, etc., etc., etc. So it would seem like a quick fix to me before I got into this, thinking just make the registrar resident, but they can't because of the hours it would impact on their training, etc., etc. So it needs to be a kind of it's difficult for an F1 to ring a surgical registrar at 3 a.m. about something which may or may not be an emergency because the F1 doesn't know. So I think it needs to be a tier of non-doctors probably supporting the juniors, not just more doctors. Do you see what I mean? It needs to be a more flexible arrangement than let's get more doctors. That's all I have to say, but do let me know if you'd like me to come back.
Thank you, Francesca. I'm guessing you wanted a final word.
Just that I think there are things that we can do. It shouldn't and doesn't, I think, need the Guardian of Safe Working to keep coming. This is for the Guardian to highlight whether or not progress is being made, and in the next quarterly report it would be entirely appropriate for Francesca to give an opinion to the board about whether the changes that Paul will present to you at the end of July have or haven't borne fruit. And that's exactly what the Guardian role is designed for, to provide another source of assurance or not for boards, because you'll get a paper from Paul that will have been through the executive and will have done all its rounds that will undoubtedly, I'm sure, give a plan. But the test will be, not to put too fine a point on it, whether the plan works, and the Guardian will hear from the people with boots on the ground whether that's the perception from there or not.
Thank you, Nick, and a big thanks to you, Francesca, for bringing forward the report and for raising the issue. As has already been commented, the board isn't not going to let go. It's very important. I mean, we know that the feedback from our juniors is excellent in general, and I think you've been quick to praise Helen, but it's very much down to yourself as well. I think they do feel immensely well supported, and long may that continue. But clearly, where there are some parts of the system that are not working quite as well as we would like, then we must address those. And I think we have a way forward. So thank you very much indeed.
Lovely. Well, thank you so much for accommodating me at an inconvenient time, Sheila and everybody else, and Nick, who was helpful too. So thank you very much. Everyone. I'll go away now.
Thank you, Francesca. Convenient.
Thank you. Bye-bye.
Thank you. Right, if I may, board, return to the agenda now, and I will come back to questions from the public. I think we've covered off some of them, because some of them were to do with the Guardian of Safe Working. got a bit of an echo. No, that's just stopped. I have a question from Liz Steele around the 3I committee. That is, if I may highlight it, and if please, when we get to the 3I committee report, can we pick up? Thank you for the full report on the 3I committees with the terms of office. Can we be assured that the new structure and brief of these committees has been or will be communicated to all staff and partners to ensure transparency? And I can see at least one of the chairs of that committee and one of the lead executive nodding. So between yourselves, when we come to that item, please could we pick that up? Because I think it's better to do it there as part of that report. And the other question I have from the public is on future systems, which is towards the end of the report. And it refers to extensive public engagement in June, July and October, November. And the question is the board happy with the level of public awareness, interest and support to push the case? And it makes the point, which I know is a sensitive one, which you will all seen in the press. You know, King's Lynn have members of the public with their placards standing on the roundabout demanding a new hospital. And I know that does cause a little bit of anxiety in West Suffolk, but no, I won't make any comments. I think it's best if we just leave the question as it is. So thank you. Craig, could you pick that up when we come to that item?
I will, of course. Thank you, Sheila.
No problem. Okay, if we could move them back into the agenda. I haven't received any other questions. I don't think I need to review the agenda again. I think I've done enough reviewing the agenda. Can we move to the minutes of the previous meeting, please? And I'll take them page by page in case there's any complexity, and try and watch your hands. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, thank you very much indeed. There is a 15, but I don't think anybody's going to raise anything on that one. So thank you very much. Can we then move, please, to the matters arising action sheet? And if I can take that page by page. The first item, the community leaders. Did you want to make any comment on that, Helen? That's 1915.
Not specifically, Sheila. Not at this stage. I think it is what it is at the moment.
Okay, thank you. And 1929 is a matter ongoing again. Helen, that's in your remit. I don't think there's much else to say, is there?
No.
Okay, I'm not seeing any questions. 1933 is not due until next month. So unless there are any additional questions, you have the information there. If we move to 1943, this one is still red and has been delayed, the SPC. Does anybody want to comment on SPC charts or ask any questions?
So this was discussed at the Insight Committee, and there's a report coming back to the Insight Committee about information and the way that will progress. So the next Insight Committee, I think, is a week on Monday. We'll get that report about information and we'll then bring that back to the board, which is why we've made the deadline the end of July. So
that makes perfect sense. Any questions on that, David?
Yeah, sorry, just linked to that one on 1931, which I know we haven't talked about yet, but that on SPC charts where we've put that as complete. I just wonder whether that needs to remain green until such time as we actually bring the SP charts back and are included in the maternity reports?
So I think the assumption was that 1931 was picked up within 1943. So 1943 talks about SPC in the broadest sense. 1931 talks about SPC within maternity. So absolutely we will pick that issue up, but it felt like we had duplicate actions.
Fine. Okay, clear. Yeah.
I think that makes perfect sense, Craig. Okay, the following items on page 2 of that report are green. I'm not going to cover them one by one. I'm going to leave you to raise the issue if there is issues or questions on any of those items. That's 44, 50, 54, 55, 57, 58 and 59. I'm not seeing any indication that anybody wants additional information. Most of them are not due. And finally, the complete actions. David, you've raised one on the complete. Is there anybody wanted to raise anything on the items on page 3 of the report, which are marked as complete? No, thank you very much indeed. In which case, could I move to the patient story, please? And Sue, I think you're leading on this month.
Yes, I am, Sheila. Just to say that, as you know, we are working with Cassia and the team to try and bring live patient stories to you, being delivered from the patients and service users. It is proving quite challenging to do this, so we are continuing to work with it. So I apologise that you've got me reading a letter again this month, but the letter I'm going to read you is a patient experience through endoscopy for somebody that's undergone a colonoscopy. And for those of you who may or may not know what a colonoscopy is, I'm very happy to explain in detail. It's my previous background as a colorectal specialist nurse. It is a telescopic examination of your large bowel. By default, it means that you have to empty your large bowel before you come into hospital to have the procedure. Through taking some very unpleasant laxatives, and very often that's the worst part of the procedure. You then come in and would normally have some sedation, and then they would put a flexible tube with a light up your bottom and then aim to get all the way around your bowel to your ileocecal valve, which will show that it looked at the entire colon. This is, as you can imagine, quite a difficult procedure. It can be very uncomfortable. In addition to sedation, fentanyl analgesia is given. People can give, obviously, before you have you're getting to the stage where you might be close to anaesthetising the patient, because it isn't a procedure that we normally do under anaesthetic. That said, it can be done under anaesthetic if required. So that's a little bit of background. And this is a lady that came through our rapid access clinic and came directly to a colonoscopy. So she writes, "Dear Cassia, I'm puzzled and tearful since having a colonoscopy earlier this week. I had a gastroscopy a few years ago, and thanks to the medication, I had no discomfort and no memory of the procedure. I will just point out that the sedation that patients are given is usually midazolam, which does mean that you don't remember the procedure. I wonder why my experience this week was so very different. After half an hour of scoping, the scope could not get through the splenic flexure." This is at the right-hand side. I won't go into detail. "The consultant spent another 10 minutes trying to get past it, and I can remember a very awful sensation. It was the most painful thing anyone has ever done to me, and I am writing this because I am so traumatized. I can't stop thinking about it, even at night. I was fully conscious throughout. Although I was told the sedation would make me feel as relaxed as if I was drunk, and the analgesia was nowhere near adequate. These medications did not work at the time or later when I returned home. I can only compare this colonoscopy with a feeling of being anally raped with a large stick. I have sympathy with the doctor, as it was the end of the day. It was a difficult procedure, and he did stop when I told him to. But surely no one should go through this in a civilized country. Why not use a smaller scope for difficult bends, or stronger medication or a general anaesthetic? I have Googled other people's experiences and also spoken to friends and medical staff who have had colonoscopies, and the best comment is, oh, they're awful. And that is when they are non-problematic. The bowel preparation medication was not very effective, which also made it difficult for the consultant and humiliating for me. I followed the movie prep instructions exactly, but it didn't cleanse the bowel thoroughly because I was taking regular painkillers. I was not told to stop taking them, but I could not go without them anyway, and no one suggested a more effective laxative. Again, I have since Googled movie prep, and it seems that many people find this very unpleasant and inefficient compared to better medications. So why is it prescribed? That or the 2-day starvation made me feel ill, cold, shaky, and with a bad headache. Today, my activities are limited because for 24 hours, I've had sharp pains in my groin near my appendix, which are relieved if I lay down, and stabbing pains in my rectum. Neither of these problems existed before the colonoscopy and are not wind pain. Because of all of this, I won't go ahead with the alternative investigations as recommended. A CT scan was booked, but I will cancel this. I would at the moment rather let nature take its course, whatever the problem is. To end on a positive note, the ward sister, wearing a red uniform, and the nurse who assisted with the colonoscopy were very kind and efficient, and I am grateful to them. And she finished by saying, we may use this letter if it helps in staff training. The letter is, the complaint is being fully investigated by the teams, and we have had some initial feedback. So we will be working with this lady and with our endoscopy teams to see how we can improve the experience of patients. But as I said at the beginning, unfortunately, and I think she quotes in the letter, everyone will tell you these are awful procedures, but we should be able to make them as less awful as possible. And I do know that in this case, they did transfer between an adult scope and a paediatric scope, which is the smallest you can use. And I also note that the gastroenterologist or the endoscopist stated that they did give her the maximum level of sedation that we were able to give, which is standard. She also did have the standard bowel preparation, which we know is not always brilliant, but it is what is advised through all of the relevant processes. So we will address this experience, and I'm just, as I say, anything, we will take it forward. I'm happy to take questions.
Thank you very much indeed, Sue, and thank you for bringing a challenging patient story, which I think is, for those in the room who've had the experience, it is undoubtedly an experience which is not pleasant, but it is not normally that unpleasant.
No.
And I suppose there are just a couple of questions before I open it up. It would be interesting to have general feedback from people who have been through that experience. Nobody is going to say it's pleasant, but as I say, I think most of us would say it was less traumatic than that lady's. And that doesn't diminish her experience at all. But I would want to know if there's any trends here or any increasing trends, because we are obviously having to do these procedures in less than perfect circumstances during COVID and post-COVID. So there's a couple of things about trends and situation that I'd like you to come back to, and I'll take some questions and then come back to you, Sue, with the number. Steve.
So I was going to ask that, but I was also going to inquire. So you mentioned about the switch from an adult to a child scope. Have we got in a sense, the most advanced scopes? Is this something, for example, that we could invest in via the charity, or look to renew our equipment?
I'm not very excited on what scopes we have within the department, but I do know that we will have. I mean, Nick might be able to answer that question, but we do have the up-to-date scopes that are there, as far as I'm aware.
Yeah.
Nick?
Thanks, Sheila. So I think it's important to try and have some perspective on what's changed and what hasn't. So it is true, of course, that COVID has affected endoscopy, but to be very clear, COVID has never affected what happens in the endoscopy room for the patient having the endoscopy. So yes, we've been able to do fewer endoscopies, people have been waiting longer, the waiting room is configured a bit differently, and so on and so on. But there is absolutely no diminution of the standard of the procedure as a result of COVID. So just to be clear about that. You wanted some feedback and sort of user experience. So I had a colonoscopy in our own endoscopy department not very long ago. I didn't enjoy it, but I certainly didn't have I didn't have a horrible experience. And I had enough sedation, and I wouldn't volunteer for a repeat performance. But if I had to go again, I would go again. I agree with this patient who wrote to Cassia that the staff are kind, the staff are thoughtful, the staff are caring. I felt that things were very well explained to me. It is true that when you are sedated, having things explained to you is a bit tricky. I remember having to ask again about something that somebody had talked me through that I thought I ought to have understood, but didn't because of the sedation that I'd had. So I think every customer's experience will be different. I think it's important to say. I don't think there's anything out of date with our scopes. I don't think there's anything. If I'm honest, it's the patient that's the variable, if you like. Everything else is constant, and that's true in all of medicine. And we try really hard to set up our systems and processes to be able to cope with that variability in the people that we serve. But it is, and there's a balance to be struck between how much you scare somebody ahead of a procedure by telling them this is going to be the most uncomfortable thing that has happened to you in a while, versus we're going to give you bowel prep. And the bowel prep comes with instructions, as the patient said, but also with a sort of warning of quite how dramatic this is going to be, and quite how gives you advice about where you should situate yourself when you engage in this activity, and you shouldn't be out and about, for example. So I think it is very user dependent, and this kind of feedback is helpful because it allows people to reflect on their practice. And I don't know who the endoscopists were, but they will of course be reflecting on that. And we have an endoscopy user group where I know that these kinds of complaints are discussed by all of the endoscopists together, because of course the other variable is the interoperator variability, but the only thing that's different every time is the patient. So I'm sorry that this was a difficult experience. I don't think it reflects the service that we generally provide in our endoscopy department. In other countries, endoscopies are done with much more sedation, something closer to a general anaesthetic. That is the standard in some countries, but it takes a lot longer. It's much more expensive, and it is one of the differences between the sort of standard in this country and the standard in some other countries. And we have come to accept and expect the standard that we are used to here. I don't unfortunately think this lady would have had a different experience anywhere else. That's the thing that it sounds like it is her particular splenic flexure that is hard to get a camera round. And of course the problem is that may be due to precisely the thing that the endoscopy is designed to diagnose. So that's why alternative investigations are suggested when things can't be completed, and why I'm sure in the response to the complaint, the team will be seeking to persuade her that another investigation an alternative investigation is a good idea.
Thank you, Nick. I can see in the chat there's a number of people who have experienced this are endorsing the positive side of this, and that is not to deny the lady's experience at all, because that is her personal experience. David, I'm going to bring you in and then I'm going to move on, but I do think there's a trend here we need to watch. And Sue, I'll give you the opportunity just to respond before I move on.
Yeah, thanks, Sheila. I can talk from experience as well, but I think between sort of scaring people, but I think equally educating people to what they can expect is really important before the sort of procedure. And I'm just wondering, how much sort of focus we have on managing expectations and going through with people what they can expect, both in terms of the medication preparation, but also the procedure itself, because I think that's very people to manage that expectation. For some people, it's going to be a very scary exercise, but I think it can be managed by doing that. I'm just wondering, what sort of focus we put on that pre-procedure.
Okay, thank you. So I'm going to come back to you, but I'll just comment. I think the written literature is very thorough, and I guess it's whether some patients need something in addition to the very thorough written material that people are given prior to this. And I can speak from experience as well. Sue.
Thank you, Sheila. And I too can speak from experience, and I have to say the bowel prep is possibly the worst thing that I could ever think to do. Anyway, the fact is, you're quite right, David. It's around the information we give to people before they come in for the procedure. And having been a colorectal nurse who managed all of the colorectal 2-week wait clinics at Addenbrooke's, I had a very good conversation with every patient I was referring for a colonoscopy to explain exactly what would happen and what their options were. As we've moved more straight to test, I think the face-to-face conversations are probably a little bit less, and we rely more on the written literature, and that may be something that we can look to make sure it's enough, and perhaps do a bit of a focus group as to whether that is enough and what would benefit people before they come in, if it would be a sort of conversation with somebody over the telephone, or a number that people can ring and ask questions for. I think, as Nick said, it's very often these people do have very different anatomy. Everybody has a different anatomy, and it's not quite as simple as just popping a tube up and wandering around the corners. It does take quite some time, and I have witnessed numerous colonoscopies in my time, and they can either be really, really simple and go straight up and round the corners, or they can be really complex. And you can't predict that for anybody by just looking at them. So we have responded. The endoscopists or the gastroenterologists are going to work with this lady to encourage her to have the onward investigations to make sure there is nothing sinister within her bowel causing her symptoms.
Thank you, Sue. And Paul, can I bring you in? And Paul, it'll be welcome to the hot seat next time, but very much welcome you today as taking on the role of interim medical director as from next month. So Paul, we give you
thank you very much. So I was just going to make the point, there's a huge amount of literature from the world of psychology that if you set someone up for a procedure that's going to be painful, they experience the pain in the procedure. If you use the language differently and say that they might experience some mild discomfort, patient's experience moves from pain to discomfort. So there is, as David absolutely rightly points out, a balance to be had. But if you talk to consultant anaesthetists, if you talk to people doing these procedures, and you talk to psychologists, the more reassurance that can be given at the beginning, setting up an expectation for some mild discomfort rather than an agonizing procedure, that actually does bear fruit and has a strong scientific background to it.
Thank you for that, Paul. And I think sometimes we are inclined to focus so much on the physical, we forget how much that interacts with the intellectual, the psychological aspects. So thank you. Good point. I'm planning on moving on. Thank you for bringing that, Sue. And I think it was one where there was quite a bit of real empathy in the room. And that's important because actually each of us experience different procedures in different ways, and we need to remember that. But undoubtedly for that lady, that was an extremely unpleasant experience. And I hope that the teams will work with her to make sure she gets the best solution for her health. So can I move on? We've had a little bit of a slow start, so I need to pick up the pace. Steve, thank you for your report, as thorough as ever, but I'm sure there were one or two things you'd like to highlight before we open it up for questions.
Thank you, Sheila, and like you, I'll save my comments for Nick and Angus for the end of the meeting, if that's okay. As a trust, we are increasingly quite busy, and so while we currently have no COVID inpatients at the moment, we have been seeing a rise in attendances, and we continue to try and recover on the elective position, and the clinical and operational teams are doing an amazing job and working around the structure and the structural work that is being currently done. Can I just say a big thank you to the Core Resilience team and the Estates team for all their work, and also to all our staff who are being incredibly both sympathetic and flexible in terms of responding to all those difficult juggling challenges. We did show our local MPs, Matt Hancock and Joe Churchill, some of the structural issues that we're working through. We also showed them the new module award that will help in terms of accelerating our structural work, and that is really coming along, and we're looking forward to that becoming operational over the next few weeks and months. We also showed them the new site, the preferred site that we are working through, and Matt Hancock did confirm, so picking up Liz's point, that we will be getting a new facility. We just want to make sure it's as soon as possible, and certainly both Matt and Joe appreciated how we are managing our structural challenges. We also, thank you, we also shared with them and discussed with our nursing and medical staff how they coped through the pandemic, and we also had a fantastic day of celebration. I want to say a big thank you to Sue, because we celebrated International Nurses Day, and that was a really great day. And I think all our nursing staff, as well as I think medical staff, took a moment to reflect on how we'd come through the last year through Innocent's teamwork and professionalism. In terms of celebration, next week is Volunteers Week, and I'm delighted to see in the papers that the volunteers are coming back into the organisation. They've been a great help through the vaccination programme, and we have had a steady stream returning, but that is increasing. So thank you to Jeremy and the volunteer team for all the work that they're doing to get them back. We'll also continue to try and improve our culture. It's good to see the Freedom to Speak Up assessment as part of the board papers today, and you'll also noted from the 3i committee reports that the involvement committee discussed establishing Freedom to Speak Up champions and a network of champions, and I think that is a great further step forward in terms of providing psychological safety to staff to be able to raise concerns. That's pretty much all I wanted to canter through, Sheila, so a couple of minutes there. Hopefully that's brief to the point, and I'll say a little bit about Nick and Angus later, if I may.
You may. Thank you, Steve, and thank you for highlighting some really key issues. Oh dear, I've got feedback again. That's better.
Sorry, Sheila. Can I just say I probably should pull out the fact that our orthopaedic teams, both clinical and medical, have delivered the best hip fracture care in the country through the pandemic. Just is an amazing testament to people's commitment and professional approach to delivering the best care for our community. That's a fantastic achievement.
Thank you, Steve. Yes, I think that's a real feather in the cap for a small DGH, which we are in effect, to be the best in the country. That really is great news. Thank you for your report, Stephen. I mean, we will come to it later, but one of the things that I see as a highlight is the volunteers coming back. We aren't quite West Suffolk without the volunteers, and I know that the team have done a phenomenal job in keeping them warm during a period that the volunteers have found so frustrating, because actually for many of them, they had their injections early on. They were very, very keen to be back, and I'm so pleased that we can begin to safely get them back into their normal roles, or into other roles if that's more appropriate. So thank you for that. Are there any questions on Steve's report, or I think we can probably say it's self-explanatory? In which case, can we move on, Helen, to the operational report, please? And again, I'm sure you will have some highlights from it. Much of it is self-explanatory.
Thank you, Sheila. Yes, I will endeavour to keep this really brief. The first paragraph there, I'm pleased to say the one COVID patient who we did have who did not come in with COVID symptoms. That was an incidental finding on swabbing. Oh. Ah. Where's that? Oh. Steve, you're sharing your screen.
And he's also on mute.
You're also on mute, Steve.
Steve, we have a problem with your screen.
Thank you. Sorry. Yeah, that patient has been successfully discharged, and we didn't have any other onward transmission within the organisation, so all credit to the nursing and medical teams around that situation, but we remain eternally vigilant. We are we are now over halfway through the ICU decant and are coping well within the reduced footprint. There have been a couple of occasions where we've required mutual aid from the surrounding trust to assist us with that reduced capacity, but that is working well. And the estates team are doing a phenomenal job and are on track to deliver that back to us. You've got a little bit of detail on page 42 of Convene. So you've seen the diagram of the gateway summary there before. Yesterday, for the first time, some guidance came out as to how we assess whether we're successful or not. So as I say, that did arrive late yesterday. It was clearly much awaited because I think within 20 minutes I had it shared with me by about 7 different people. So lots of people looking out for that one, and we need to work out now how we measure up against that. But that's good news. And then you can see at the bottom the range of various actions we are taking, things we are working through and considering, many of which are in an advanced stage now, to address our shortfall in theatre capacity, which starts to impact on us from next week. We did manage to continue to work through May, and I'm very grateful for the estates teams for adjusting the ward plan accordingly to realign it with the theatre plan. We delivered quite a bit more theatre activity through May as a result of that, and the teams are working really hard now to mitigate the shortfall that is coming. And in terms of the final accelerator programme, detail is emerging literally day by day. And so the plan is to bring a more detailed paper around that to scrutiny committee. It will be the best information we've got at the time, because I do feel we're a little bit in a moving goalpost position. But other than that, and then you've got the appendices at the end, which show the data. Just to be clear with people, you've got a point in time. I'd ask people more to refer to the 4-week columns, the 4-week average columns, because the latest week is always provisional data and there's data catch up, which is why some of the percentages appear to drop off a cliff when you look at that. But I'll leave it at that, and happy to take questions. Sheila, I can see I've got some hands up.
Thank you very much indeed. Angus, can I bring you in, and then Louisa?
Thank you, Sheila, and thank you, Helen. I know it's implicit in your planning, but I'm just conscious there's a sentence in your report that talks about the possibility of a third peak. And I wondered if you could just give some assurance to the board how that plays into your planning and how you're taking that into account?
Yes, absolutely, Angus. It's an element of educated guesswork. However, we benefit, as we always have done throughout this, from having our own public health clinicians, and certainly they have done the usual process of applying some West Suffolk specifics onto some of the various national models. So that is helpful. The suggestion at the moment is that we're probably looking at a lesser impact in healthcare when we see a significant increase in the population, and some of that is absolutely the vaccine programme, and hence you can see lots of effort going into increasing that. We are also nationally and locally, we're now being asked to send positive samples for specialist analysis at Porton Down so that we can track new variants, because that's the latest kind of concern. But what we're looking at is probably, guesswork, sometime at the end of August, September, an impact of potentially up to 20 cases in the hospital. Now, that does take more capacity, because we then have to start having redundant capacity for different pathways. However, this really comes in line with having got G10 online, which will be helpful, and we would designate as that COVID capacity because it's a much better facility for infection prevention and control. We also are, to an extent, we're crossing our fingers and hoping that it aligns with the completion of the end-bearing support work. But there is a possibility that towards the end of that end-bearing work and the beginning of COVID, the two things will align. Now, what I would say is this is all a judgment and a risk assessment, and we are closing capacity to do the end-bearing support work as quickly as possible. But if we found ourselves in a position, we would have to have a risk-based conversation about, do we need to slow one thing down in order to accommodate the other? But we're very sighted on both.
Thank you.
Thank you.
Thank you, Angus. Louisa?
Helen, given the challenges of the structure, both ours and other acutes across the region, can we seek assurance that we're coordinating our EPRR response regionally? Should, for example, the communications from Queen Elizabeth say shut part of their facility, or there be, as you've alluded to, pressures within our own facility? It's just, I've always had an adage that if you plan effectively, it may not happen. So it's just really, have we got those plans in place and have we exercised them?
So there is absolutely a regional planning and coordination group, as well as a CCG focus around that. I think it's fair to say, is it done and dusted, Louisa, and on a shelf? Probably not, because it's an iterative process. There is a plan for us to undertake another, it's not quite a live exercise, but a real exercise, and we're working with the estates team to try and find a day where we can get into an empty ward while it just between moving from one ward to another as part of the decamp programme, so that we can exercise that scenario. And we're also working obviously with the Ambulance Trust and regional colleagues, because our exercise takes us to the borders of the property, and as you quite rightly say, it's what happens next. So there is a lot of work going on in that space. Is it complete? Probably not, but it's got a lot of focus and attention.
Craig, I see you've switched your camera on. Did you want to come in point of view?
Not particularly, Sheila. Helen, I think, has explained it perfectly. We did do exercise Hodges as a region.
Yeah, we did.
About 6 to 8 months ago, which was exactly what Louisa was saying. But I think there was learning that came out of that exercise. That was about evacuating effectively all of the RAC-affected hospitals. And I think, as Helen said, there's learning that we need to embed.
And as I've articulated at the board before, at the strategic level, the chairs of the RAC Plank hospitals, those in the Best Buy group, are meeting on a fairly regular basis to discuss strategic approach. But it's good to know the real work's going on beneath that. Thank you.
And just to add, Sheila, we did have a meeting with Anne Radmore where we took Craig and I with the CCG. We took them through both our plans, but also did discuss that need to make sure we've got that coordinated regional response, and that needs to be, both progressed and really planned, as you're suggesting, Louisa.
And thank you, Louisa, for joining the latest of the regional meetings on my behalf while I was on leave. So Rosemary, can I bring you in, please?
Yes, thanks, Sheila, and thanks for your report, Helen. I just had a question about outpatients. One of the objectives of the accelerator programme is transformational change of outpatients. And I wondered if you're already working on that and what the timescale for that transformational change is. But meanwhile, can you give sort of assurance that there's an action plan to improve performance of first outpatients and follow-up outpatients, please?
So you've hit on a really interesting dilemma there, Rosie, because if we transform, the two things are diametrically opposed, and this is something that the national team haven't quite got their heads around, because if we deliver on a number of the transformational changes, particularly in the follow-up space, but actually those things are designed to reduce the amount of people coming for outpatient appointments, and therefore delivering more activity in outpatients than we used to, whilst transforming our services to deliver less, is the dilemma we're currently working through. The plan is absolutely in place, and actually in a lot of ways, Rosie, we're ahead of the national expectations. So it includes things like advice and guidance, which is a GP can access a consultant for advice to manage the patient. That impacts on the number of first outpatients. It includes something that a little while ago nobody knew, but now we have a new acronym, which is PIFU. And PIFU stands for Patient Initiated Follow-Up. So I've got a long-term condition. Historically, I was brought to the hospital whether I needed to come or not every 6 months. And if you didn't take that 6 months, actually, you missed your slot kind of thing. The idea is that we reduce that where possible, and we bring those patients we put safety nets around them. They can send us results of tests on a virtual basis, and we bring them to hospital on a fast track basis when they need to come, rather than because it's 6 months since they last came. Virtual outpatients is another one. Now they will count as slots even because somebody's talking to you, but there's a variety of options. And then there is a further stream of work which sits under the accelerator programme, high volume, low complexity pathways, which looks at people more on an elective rather than people with long-term conditions, and is looking to say, how can we reduce the number of visits and streamline the pathways? But absolutely, there's a programme charter and a plan to deliver against those things.
Good, thank you, Helen.
Thank you, Helen. And thank you, Helen, for the report. I mean, it's clearly a time of juggling an awful lot of difficult issues. And so thank you. And thank you to your team, because they're the ones, who are at the forefront of the juggling.
They certainly are. Sheila, Nick's got his hand up. I don't know.
I've just spotted that. Thank you. Nick, you get the final word before I move on.
Thanks, Sheila. It's just to add to what Helen was saying in response to Rosie's question about outpatients. Really pleasingly, those transformation groups have consultant involvement in them, because there is a real anxiety amongst my colleagues about the added burden of some of this. So if you, particularly PIFU, our consultant job plans are traditionally divided up into different aliquots of work, and an outpatient clinic is one of those. The trouble with PIFU is it's like an outpatient clinic without an appointment, and so the appointment slots get filled with other patients, and so their clinic is still full. And then there is the PIFU patients who need attention as well, and we are going to need to start working out how we allocate people time in their job for that. It's absolutely not that we are trying to get people to do stuff without time to do it, but the trouble is we've not traditionally had a way of marking out that time, and we will need to. The advantage that you've got is that your next medical director is much more familiar with the outpatient setting than your current medical director, so I think you'll be in good hands.
Thank you for that, Nick. Okay, thank you all very much. And in which case, can I move on? And we'll come to the first report of the 3I committees. And I'm really pleased to see these here, because I think they give the board an opportunity to really shift its focus on the strategic elements of governance, while ensuring that we keep the grip on the bare bones of governance beneath that. I would ask that we bear in mind the question Liz asked as we present. Now, unfortunately, we have two of the chairs of these who aren't present today for various reasons. So, Sue, would you like to kick off? I think you're probably first on the list.
Well, Craig was first with the go straight to involvement.
No, we'll go through in order. We'll go to Craig for insight. Sorry, Craig.
That's okay. Thanks, Sheila, and thanks, Sue. So you've got details of the discussion that we had at the Insight Committee. This was the inaugural meeting, so as you would expect, there were discussions about the terms of reference and the membership. That will be a recurring theme as you hear reports from each of the three meetings. I think it's probably worth saying that, and particular in response to the question, I think it was Liz's question, the communication is a really important part of this, and we did have discussion at the Insight Committee about making sure that it's clear to the organisation and through this board, the wider population that we serve, the purpose behind this. It is about getting, in particular, clinical involvement in the governance of the organisation, and making sure that we have a process whereby we interrogate data about what's going on in the organisation, and that we triangulate that data with other sources of information, whether that be complaints, whether it be patient stories, whether it be governors or the public. And then when we find issues, that we then focus on improvements. And that, so you can see through the new structure, the insight is about scrutinising the data, involvement is about triangulating those the issues that are highlighted, and improvement is about continuously improving the organisation to increase levels of quality. And so things should circulate around the governance process. It's therefore important that there is some consistency in membership across those three groups, and ensuring that the membership of those groups reflects the broad nature of the organisation. So that was some of the discussion that we had at the Insight Committee, and I know I'm stealing the thunder from some of my colleagues when they'll talk about the others, but I think the fact that I was going first, I think it's important to set the scene. and therefore properly communicate it. And Liz's question was really important, because it's really important that the organisation understands this and knows the way in which they can feed in issues. But a genuine philosophical change, one of encouraging curiosity and interrogation as to what's going on in the organisation, so that we can genuinely improve the services.
Thank you, Craig. That was a great introduction and really set the scene, as you say, for the three committees. And what I sense from everybody who's involved with those is a real sense of energy about this and a real shift in the way that we approach our committee work within the organisation. But it is a change. And I mean, one of the commitments we've made to the governors, for example, is there will be evaluation of the progress of this as we go. It's important that we take the lessons learned, and that if there are aspects which are not working so well, we acknowledge that and do something about it. So thank you, Craig. I will pick up questions, I think, at the end. I think I'll go through the three, because there is some very clear similarities about all the reports and about where the different groups are. So next on the list is Sue. Sorry.
Thanks, Sheila. So we like the insight. Well, I'll just echo everything that Craig said. Is exactly the principles that we have adopted within the Improvement Committee. So the Improvement Committee will be about, and as it's stated out there, is to look at sort of a centralised holistic approach to improvements. So what we're hoping to achieve is that complete oversight, support and development of what have been and will be identified as potential areas where we need to demonstrate improvement. But what we don't want to do is overwhelm the committee with lots and lots of superficial discussions each month. What we want to do is make the discussions and review really in depth, and allow the individuals coming to have that time, and for us to truly understand where we're at and what requirements there are, and then how we link into the Insight and Involvement Committee. So Craig's quite right. Most of our data from improvement will be reviewed at the Insight Committee, and we will rely on that cyclical data processes to be able to demonstrate the improvements that we are required. We did have, as a bit of a proof of concept, we had Helen Dockrell, who came and presented her falls improvement plan and the work they're doing around falls at the Improvement Committee, which I think did demonstrate really well how we can have that information brought to us, how we can have a really good discussion about it, and then how we can agree as a committee what we want to do going forward. And next month, I'm hopeful that we'll get deteriorating patients, which will be a plan that encompasses all that we are learning through all of our resources, inquests, SIs, near misses, etc. And we will have a sort of a high level overarching improvement plan with detail underneath it. And I think it's a really good opportunity for us as a committee to be able to see that and offer support. And of course, James McFarlane, who is our Associate Director for Quality Improvement, is heavily involved in all three committees to ensure that we're not losing sight of the methodology and the ability to drive and lead equality improvement. I don't know if Richard wants to add anything, because Richard, this was you were chairing this meeting. Sorry, David, you mean? Oh, David, sorry.
Yeah. I think just one of the other things is that there's the slight difference in approach. So I think obviously this is transitioning from the Improvement Programme Board, which was set up in response to the CQC report. And I think this new committee is much more about driving improvement ourselves, so internally. And I think the other aspect is that we're also wanting to use this new way of working to empower people within the organisation to drive those improvements themselves. So I think it fits very well with our cultural agenda. And I think that's also why communication is so key, so that people really understand how this is going to work, where they fit into it, and to give them the confidence to participate and engage with the total process. So, and I think one of the things that Sue has suggested, which I think is a great thing, rather than have agendas flooded with lots of different agenda items, we will bring people to the committee, groups of people on a rotational basis as part of their development and training as well, to give them the sort of confidence to participate, but also to provide them with the tools and the training to be able to drive improvement themselves, because I think that needs to be done from a base level, not top down. So I think it, as well as a change in structure, I think it's almost a change in philosophy in how we're going to approach these things.
Thank you, David. And I think next board meeting, when we have all three of the chairs there, I'm going to start with the chairs before we move to the executive, if that's okay, in board. So putting you slightly on the spot next meeting. I think that would be really helpful and part of that new philosophic and cultural way of working. Thank you for that. Jeremy, in Alan's absence, can I ask you to go over the report back from the involvement committee?
Yeah, thank you. So Alan is the chair of the committee, as you say. I'm the lead exec. Rosemary is also here as one of the non-execs, one assigned to involvement. So Rosemary may want to chip in. Just taking things a bit further, really, building on what colleagues have already said about the other two committees. Within involvement, it has the potential to be overwhelming, because of course we want everybody to feel involved in our plans and in the work that we do as an organisation. So in terms of trying to organise ourselves, we've identified the three communities: staff, patients and our partners in the system. And as the paper says, the ultimate success of the involvement committee is that those three communities feel much more involved in the work and planning and decision making of the organisation. One of the things that we heard back in the What Matters to You work last year was around the prominence and platform that we give to subject matter experts and lead professionals within our organisation, and how we could improve that. And that is one thing that the involvement committee will do. It will create that space for the board to be influenced by subject matter experts within the organisation, as well as receiving referrals of issues from the other two committees and from board itself, for us as an involvement committee to delve deeper. In addition to talking through those guiding principles at our first meeting, we also focused in on two pretty meaty areas of work, which is detailed in the paper. One is around the proposal from our Freedom to Speak Up Guardians to create a much bigger network of Speak Up champions, which Steve referenced in his report earlier in the meeting. And then also myself and my two deputies, we presented on the work we've been doing during May to engage people on the development of our longer and stronger people plan for the organisation, learning from the staff survey results. There's some commentary in the report in relation to that. Thank you.
Thank you very much indeed, Jeremy. Rosemary, did you want to add anything before I move to Craig and Steve?
Yes, just briefly, because the major items have been covered quite eloquently. But I think the involvement committee is an important element on the cultural sort of change programme that we've got underway in the trust. So it's about obviously involving people, but listening, encouraging and supporting people. And I think it's going to be interesting to watch the progress that we make over the coming months. So for instance, the two topics we've picked for the next meeting are line manager development and competences. And also Paul's going to bring forward a piece on supporting staff in stressful times. So it's about how we can empower people, as the others have said, to bring forward programmes, and how we can enable them to deliver the programs within the organisation. So it's not about them asking permission, it's about enabling them and empowering them to feel that they can take these pieces of work, talk about them, and then roll them out into the organisation. So, and finally, what I would say is that we've had some discussion about how we can measure our performance, because really in this committee we're talking about qualitative data rather than numbers and so on. So we have to be very clear that we've got some key ways of measuring the progress that we make in the committee, so we can actually demonstrate we're not just talking, we're actually delivering.
Yeah. Thank you, Rosemary, and that's a joy to my heart. It's part of the evaluation to me, you know, that we need to measure what's important and not what's easy to measure. Thank you. I think they are great reports. They are a great beginning, but I'm going to take 3 more speakers before I finally sum up. I think that I'm very grateful to all the chairs and the leads, both for the enthusiasm, but also the really positive, measured thinking around the roles of these committees. And the one word I've heard across everybody is this linking together, because that to me is really important, that we don't move into a situation where we just create new silos. Craig, then Steve, then Helen.
Thank you. I was just going to expand on some of the things that's been brought out. One of the ways in which we are going to communicate this to the organisation, as well as ensure that the process will work, is to try and use real life examples. So we have had a discussion about maternity services where it's evident that there was a difference in perception as to the quality of the service, and indeed some issues that we weren't fully cited on. So we were going to use that as an example, both to ensure that the process that we've got is fit for purpose, so we can test out the process to see whether it would work in identifying those issues, but also help to communicate that both to the organisation and the wider public. So using stories is always a very powerful way of communicating things. We'll seek to do that for this change.
Thank you, Craig. Steve, and then Helen.
So I was going to make a similar point and bring in the other Helen, because I think we need to consider how we communicate through case studies to the organisation and to our public. But I just wanted to say I think this is hugely exciting. I really thank my exec team and the colleagues for all the effort that's gone into thinking about doing this differently, because I do think it signals a cultural shift to becoming a more curious learning organisation. We've got to be very careful, though, that we don't let things fall through the gaps, and so we need to make sure that we are reviewing as we go along and just making sure that we are not losing sight of things that we need to have board assurance on. And I know I think that is a shared concern right across the board table, and we'll work that through both through scrutiny and through to the main board. So I think it's just important to just reiterate that this is huge potential, but not without risk in making such a major change, and we just need to be live and wary of that.
Thank you, Steve. Helen.
Thank you, Sheila. I can attached to the paper is the full IQPR as well. As part of this and to create the space for these conversations, we were quite clear that we weren't going to spend a lot of time diving into the detail of that at board, but I just wanted to pull out an example. So something that's really worrying me around what's sitting in the IQPR, and I think we're carrying clinical risk around, is endoscopy. So that's playing through in the diagnostic performance. Because what you see in the IQPR is an aggregate of all sorts of things. Because endoscopy is such big numbers, it does affect. But Cystoscopies are a worry to me, but you will not see those in this data because the numbers are so small, they disappear. And I think that's quite a nice example of where, sitting underneath the Insight Committee, we are establishing some more robust groups to review that. But also the endoscopy, and I count cystoscopy in that, it's just a different orifice. There is a very detailed paper that is going to come to the next Insight Committee that picks up all of the issues and the challenges around endoscopy and what we're doing about them. There's been quite a bit of improvement, but I think it will be for the Insight Committee to then determine, are they comfortable with the trajectories and the speed of improvement, or actually is that something they wish to hand across to the Improvement Committee to have a deeper focus? And I just thought I'd share that because that's a real example and probably one of the earlier ones that we will start to look at the very next meeting.
Thank you, Helen. And I think that's a really good illustration because it illustrates the challenge for the board too, in seeking for the board to have more time to be more strategic in its discussions. We must not lose sight of some of the exception issues. I mean, the worry issues, and the very positive as well. It's where we're away from trajectory. It's where there's a challenge, and where there's a challenge which the board as a whole needs to own and needs to discuss in a public forum. So, you know, I'm a little bit where Steve is. I think that I'm enthused, I'm excited, I'm energized by what we're doing. I'm very clear it's the right direction to take. But we do have to be careful that we don't drop any governance balls, so to speak, as we move forward. And we do need to make sure that the board doesn't delegate any of its key responsibilities in a way which would be unhelpful and actually not appropriate to board governance. So I think exciting, lots of challenge here, a really good beginning to the committees. I think the ongoing evaluation, tracking our progress, talking to others who within the trust and outside the trust about how that's proceeding is going to be absolutely key. We don't have all the answers, but we're doing the right thing in the right way. So thank you all very much for your reports from your first meetings. I shall look forward to those at the next board meeting. Okay, thank you all very much. And on that note, I'm not suggesting the finances aren't exciting, Craig. They're a little unusual at the moment because we're still in the COVID era.
Thanks, Sheila. Finance is always exciting. So, having said that, this is month one, and of all the months, month one is probably the least exciting. I know the bar is high, but that's just where we are. The figures in month one are always heavily influenced by the year end, and we went through the year end position at the last board meeting. So the position we are reporting is one of at the board previously agreed the financial plan for the first 6 months of this year. That's the national process because the first 6 months is being dealt with separately to the second 6 months. We don't yet know what the assumptions for the second 6 months are going to be. So board submitted a plan that has subsequently changed, and you can see some of the details in the finance report. So our plan now is to break even for the first 6 months. That's principally because our income position has been set on the basis of the expenditure that we incurred in the second half of the last financial year, so heavily influenced by our response to COVID. The key thing that I'm concerned about this year is capital. the bulk of our capital programme is consumed by our response to the structural issues that have already been discussed at this meeting, and do form the backdrop to a huge number of meetings that we have both within and outside of the organisation at the moment. So our plans at the moment are that we will spend around £30 million on remediating the structural issues this year, and that will be a feature of future years. Having said that, the rest of the capital programme is severely constrained, and we are having to deal with, on a daily basis, some of the problems that constraint on capital is causing. It does appear that the entirety of the NHS's capital budget has not yet been allocated to organisations, so we are heavily engaged in conversations with both the regional office and the national team about accessing additional capital and detailing some of the issues that not having capital will cause the organisation. So other than that, I think the financial position is somewhat anodyne for the first month, but capital is the focus of my attention at the moment.
Thank you, Craig. David, can I bring you in?
Yeah, hi, Craig. Just a quick question on SIP. So the SIP target that we set for this year was 1% plus any unrealised targets that we had for the previous year. And I think we ended the last financial year with about 4.2 million behind. While SIP is not necessarily an issue immediately, it might catch up with us. I'm just wondering how we're going to keep a focus on that 4.2 million that we didn't actually achieve last year, given that the sort of SIP focus in the paper is just on the 1% at this point.
Yeah, it's a good point, David. And part of the problem is what I was alluding to in my presentation, which is there is still some uncertainty. So we're having to redraw the financial plan that we had for the first half of the year, and our SIP programme will therefore fall into the second half of the year. So we're currently working that through. You can see in some of the commentary from the divisions that they're talking about the shortfall in the SIP that's been brought forward from last year. So we have some work to do in properly determining what the balance will be required in the second half of the year, and we'll look to bring a much more complete illustration of the SIP process to the next board meeting and subsequent ones. But you're right to highlight it as problematic at the moment.
Yeah. Okay. Thank you.
Thank you, Craig. I mean, it feels as if we're still in a very unreal world in terms of NHS finances. I suppose, do colleagues of yours have any sense of when we might get back to more normal service, which will be much tougher, because it's a bit illusionary at the moment?
I think that's right, Sheila, and we've already had a discussion at this board meeting about what the next wave of COVID might look like, and I think Helen tried to convey some of the uncertainty around our planning. That uncertainty is reflected at all levels of the NHS. We've seen nationally the number of patients in hospital climb over the last week, and therefore nervousness about what is happening is present across the NHS. That's reflected in uncertainty around the financial position. We still don't know what the overall allocation to the Department of Health is going to be from government this year, and so setting financial plans is almost impossible. I think you're right, and we at this board have focused in the past on what the longer term financial position is likely to be, and trying to plan independently really for this organisation and what a return to normality might look like. So I would propose, and we are indeed still progressing with that, to try and work out what our own underlying funding position will be, and therefore what the SIP requirement for this organisation would be. But I'm doing that independently of the rest of the NHS at the moment. I think that's the right thing to do, but I don't know when we'll get certainty. We have certainty around the first 6 months. I would expect within the next couple of months to get certainty around the second 6 months of this financial year. But as I've said, I don't know what that's going to be.
I suppose I shouldn't wish normality back, but I'm really pleased you're doing that work, Craig, because I think all of us have a nagging worry about we'll suddenly turn a corner and we'll be facing some very real financial challenges, because the economy is not going to be in the best of states. So there's, it's a worrying period, and it's good to hear that as a trust, we're taking some responsibility for it for ourselves and preparing ahead for that. That gives me great assurance that we are as prepared as we can be for what we don't know whether it's going to happen. Thank you. Are there any other questions for Craig or comments for Craig? In which case, Craig, thank you for your report, and thank you for the ongoing work you're doing in the background around the future. We are running slightly early, which is unheard of in my chairmanship, but I'm going to suggest you take your 10 minutes break, make yourself a coffee, and come back for the second half. So we will resume at 11, please, sharp, for the second half of the board papers. Thank you very much indeed. your report, and of course we've done the Francesca's report, so we can take that one out. But for the rest, I'll hand over to you to run through. And welcome back, everybody.
Thank you very much. So first and foremost, the two Putting You First winners that are detailed on page 83 of the pack. The first one nominated by a colleague, the second nominated by a patient. So that's Emily Fell and Chloe Bonner. And I think what shines through in both of those is the really personal focus, the particular needs of those individuals at the right moment in time. We were reflecting on how that makes a difference when we were listening to the patient story earlier. And that, for me, that really shines through in these two nominations. So as a board, we record our huge thanks and appreciation to Emily and to Chloe for the exemplary care that they provided in the two scenarios that are described. So thank you to them both.
Thank you, Jeremy. Thank you for highlighting those, because they are great nominations.
I wanted to move now to the board self-assessment document, which is presented for approval today. So this is a template self-assessment that was first published for NHS boards just shy of 2 years ago, and West Suffolk last went through this self-assessment in the autumn of 2019. It was presented to the board then. Since that time, there has been much that has happened and much that has been commented on in relation to our approach around supporting staff to freely raise concerns in confidence. And there's been much that has been worked on in that time. There is still much to do further work on. So it was felt now was the right time to refresh that self-assessment. It is, as I say in the paper, very much the board's self-assessment. It's not designed to be delegated to anybody. They are lines of inquiry for us as senior leaders to reflect on. But in preparing this for today, I have consulted comprehensively with our two Freedom to Speak Up guardians, with Richard Davis as our named non-executive director for Freedom to Speak Up, and also with members of my own team who do a lot of the work, the background on this in support of our Speak Up guardians. This self-assessment has the input of all of those that I've named and their support. Yeah, it is presented for questions, for comments, and I hope approval from you today. It does detail the areas where we need to do further work on the right-hand side of the template. That reflects the proposals that were brought forward by James and Amanda as our Speak Up guardians when they presented to us last month around the sort of even better if we did these things as well. You will recall. So all of this will be joined up into the plans that will be incorporated into our people plan, as we mentioned in the Involvement Committee report. So I'm going to pause there so we can cover that item, and then I'll cover off the rest afterwards.
Thank you very much indeed, Jeremy. I suppose I've got one question, and it's actually around the fully met, because it seems to me that this is an area where there's a lot of qualitative judgment here, and a lot of psychological sense of whether people feel psychologically safe. It's quite a difficult area to assess. So on the fully met, how do we keep, we need to keep testing that, would be my point. It's a bit like in the improvement board where it was important to make sure that things were properly embedded. So how do we make sure that fully met isn't ticking the box, but not embedded, because that's what we need it to be. You can hold that as a thought for when you come back at the end. But for me, that's crucial. We are great at measuring what's easy to measure, not what's really important. And that it comes into that category as well. But I'll shut up at that point. And David, can I bring you in, please?
Yeah, thanks, Jeremy. A lot of detail in here. Just on page 7, I think one of the ones that's really important for me is the expectation around evidence that you receive assurance to demonstrate that the speaking up culture is healthy and effective, because that's what we really want to see at the end of the day, that it's actually working. A lot of the actions are sort of what I call more formal ones in terms of reporting and things. I'm just wondering whether we should be considering some sort of informal mechanisms to actually touch and feel the organisation, to really feel that there are changes there and people are happy to speak up. And how do we actually achieve that?
Do you want to hold that one, Jeremy, or do you want to come back on that one? I'll take Steve next, and then we'll come back on the early questions, and we'll see if there's any more.
Thank you, Sheila. So I think this conveys the journey that we're on and the actions that we've got in train and the further actions that we need to do. There are some qualitative judgments clearly around this, Sheila, but I think it's important that we err on the side of caution, that we don't be complacent about the work that we need to do. And I don't know whether colleagues are aware today, the National Guardian's Office has published their report on the 2021 Freedom to Speak Up Index, and in that paper there are 3 case studies around the Isle of Wight Trust, East Midlands and South Tees Hospital Trust, and it might be that we look to those case studies and engage with the Guardian's Office around additional things that we could do to add to our list of actions to enable us to further improve the culture and so forth. So let's see if we can take on board some of that lessons, some of those lessons and learning.
It's a very good point, Steve. Thank you very much for that. Are there any other? There's nobody else waiting to come in at the moment. So Jeremy, can I come back to you with those early points that have been raised?
Yes, absolutely. So I think there are some lines of inquiry in this template which are relatively straightforward to answer. You know, do you have a named NED? And there are some lines, that's one end of the spectrum, and there are lines of inquiry which are deeply cultural, which actually, if I think about it, I'm not sure I would. Well, I wonder what position I would need to be in to be able to say fully met. That's quite a confident. It's quite a confident statement to make for something that is so deeply cultural in an organisation of over 5,000 individuals. We talk about culture quite a lot, but of course the truth is that there are lots of microcultures within any organisation, and what is true for one team in an organisation won't be true for another. So to really come to David's point, I think that's the thing I struggle with, David, is getting that assurance. The experience of our staff will be different dependent on the culture that exists within that team. We referenced earlier, so Rosemary talked earlier about the focus around the responsibilities of line managers and team leaders. And I think for me, that is the next step of our journey on this. I think that we've been working on things at an organisational level in relation to speak up culture. What we need to do now is to delve down into the layers of our organisation and support and develop line managers who have an appreciation of what their role is in creating the right culture for their team. From that, I think we then need to think about how we answer your question, David, which is around, well, how do we then get assurance of that? The staff survey results do help in that regard. We know that it was really the number one concern from the 2020 staff survey results, and we used the previous year's staff survey results to identify teams which reported lower scores for this domain. and we are doing the same again with the 2020 staff survey results. So that's another way honing our support into those teams that need it most.
Thank you for that. Is there anybody else who wanted to come in on this? Because I think this is quite an important work. Nobody is coming in to dispute the where you have placed the fully met or not fully met. I think I get the sense that people are reasonably comfortable with the estimation there, and you've involved the right people in that assessment.
And you will note, Sheila, that even for the fully met, they still possess a review date of 6 months' time. So we're not sort of saying that that's okay forevermore.
That's my point about embedding. I think, and it's really important that we keep checking that. It isn't something you tick off the list. Rosemary, you wanted to come in.
Yes, thanks, Sheila. Jeremy, it's great to see the progress that we're making in all of these areas. Mine's a sort of a general point. You've made also good progress in the appraisal programme as well. And I was wondering what your thoughts are around how we take appraisals, if you like, to the next level, which is linked to the freedom to speak up, which is there going to be any work done around succession planning and training and skills development, which is very much linked to this, isn't it? I mean, it's separate, but it's also linked to this. I wondered what your thoughts were about how we can build on appraisals to develop the skills of line managers that feeds into the Freedom to Speak Up programme. For instance, I know it's broader than that, but...
So I think the thread that runs through all of that is relationships. If the right relationships are in place where people feel safe and they can trust colleagues and senior colleagues, then they will feel able to pick up. They will have a more meaningful appraisal conversation. It will be less transactional and it will be more it will be more developmental. So that relationships point is right at the heart of how we support and develop great line management in our organisation. And we already have many line managers that understand that and appreciate it and create that environment for their staff. We need to make sure it exists everywhere in every team, because it doesn't yet. And the work, as we discussed in the involvement committee, the one of the three big themes that come out of both the staff survey workshops that we held in May was around what further work we do around supporting line managers and the development of those. So yes, that, and then that all flows out of how an enhanced focus on quality of appraisal then helps people focus in on succession planning and the like.
Thank you, Jeremy.
Thank you, Jeremy. I haven't got any other questions, so I think that we would be happy as a board to agree and approve and concur with your estimations, which you have reached, involving people like Richard Davis and the Freedom to Speak Up Guardians quite appropriately. I think that we've got a review date later in the year, which is good, because I think this is something of considerable importance to the Trust and we need to keep coming back to it. So thank you for bringing that, Jeremy, to the board today. And Jeremy, I think as we've already covered the Guardian of Safe Working, that is the conclusion of your report for the moment.
Yes, absolutely. We've already covered the volunteers piece in Steve's report. He has a habit of picking up my items from my report. I'm putting your leg, Steve. And there are some other updates in there just for information. So yeah, that covers everything.
Okay. But before I go, I can see that Angus has got his hand up. Angus.
Sorry, Sheila, there's a danger that I'm, very much just arriving at the last moment on this agenda item.
That's right. Just what I told you.
Just a sort of governance reflection in the Freedom to Speak Up tool, which I think is excellent, is ensuring that when the involvement committee reports to the board, it consciously comments on the progress on this when it reports. to demonstrate the ongoing consideration of it rather than waiting every 6 months just to sit down and have a think about it.
That's a good idea. Well made point, Angus. Thank you.
And of course, in addition to, if we stick with a 6 monthly review of this tool, we also have the 3 monthly reports to board by our guardians as well. So that also provides an opportunity for focus and momentum.
Thank you, Jeremy. Thank you. Good points. In which case, I'm going to move on now to the next section, which is the quality and safety reports. And I'm going to come to the maternity one first. And Karen, I think you've joined us. Good morning, Karen.
Good morning, everybody.
Nice to see you on screen. So, Karen, I'm going to hand over to you for the maternity report, please.
Okay.
Thanks, Sheila. I'll hand over to Karen.
Thank you very much. Hopefully you've all received the paper and have read it, which will be fantastic. So the highlights to you, first of all, is regarding eCare. So as you're aware, we went live in March, and there has been some issues with the data analysis and able for us to capture some of the data. So that is a significant issue at the moment. It has been escalated, and we are working very, very closely with the eCare team and the information team to resolve this. But that's why there is missing data from this paper and previous papers. But hopefully we will have a resolution soon. The second thing just to bring to your attention is regarding Ockenden. So the Ockenden portal is now open for us to embed our evidence of how we are meeting all the requirements with the Ockenden report part 1. We know part 2 will be coming out later on this year. There is masses of data that is required, and what we will be doing, we are having it checked by region before we submit it, but we will get it signed off by the execs, which is planned for a couple of weeks before we do submit it. The portal was due to close on the 14th of June, but that has now, because I think everybody has recognised the amount of work that is required for this, it is now open till the 30th. Sorry, I can see someone. David, you got your hand up. Did you want me to?
Yeah, sorry, just the eCare, because obviously having access to good quality data is so critical for this area for us to be able to evaluate, where we are and the improvements going forward. And you mentioned that there's a need for a business case for maternity digital support. So I just wondered if you could tell us a little bit more about what that is, what stage it's at, and what the time frame is, because I think we all want to be able to rely on data to evaluate exactly where we are at any particular time.
Absolutely. So we have met. So we've met with the execs, eCare, information, and maternity to discuss exactly what is required, and that's where it goes slightly outside my remit of understanding fully the issue. It's very much the data is there. It's just got to be pulled through and put in the right domains for it to come through for data to be able to pull reports. So we have got people in the background who are doing that. So we immediately we've taken action, and we have got people from eCare helping to what's called data cleanse to bring that information through. So that is happening immediately. I have spoken to Ian Coe to look at us maybe potentially seconding somebody into a digital midwife role, and that will be as quick as we can possibly get it to happen. So I think our next step is to regroup as the execs team, but eCare, the information team and maternity to see where we're at next. So the time frame is, I assume it's going to be in the next couple of weeks.
Okay, so I just wanted to get assurance that the resources that are needed will be from, the relative execs, I suppose, Sue.
Yeah, absolutely. And for now, there is absolutely the support there. So the work is going on that a digital midwife would do, but obviously long term we would need to have somebody in that position.
Okay, thank you.
Yeah,
thank you, David.
just whilst we are just going back to Ockenden, so one part of Ockenden is something called the Perinatal Surveillance Tool, which is about how things get from the floor to the board, then to the LMNS, then to the region, and then the national team. So on this paper, some of the standing items, for instance, the Safety Champion walkabout, feedback from friends and family, service users feedback, they are all items that need to be captured and shared with you as part of the perinatal surveillance tool, so that we will be meeting those requirements. Then obviously the dashboards, they are limited this month, so we have got some data that is missing. And then just finally, I was just going to update on the CQC. So we know that we had a visit. We are expecting the report imminently. So as soon as that report comes through, we will obviously be looking at it for factual accuracies, which I believe we will have 10 days. But any actions that have been highlighted to us, we will be acting upon. But the actions that were highlighted to us from the immediate feedback, we have already worked on the majority of those and fed that back to the CQC of what we've done. Thank you.
Thank you, Karen. Thank you, and it's great to have at board. Are there any questions from board members? I think David's covered mine beautifully, so I think there's nothing else I want to raise. Nick, you wanted to come in?
Only to try and just add a bit of colour to the e-care situation, if that's all right, Sheila.
Yes, absolutely.
So I did a maternity safety champion walkabout this week, and for probably understandable reasons, I thought I'd focus on e-care and see what people thought about it. And the overwhelming view of midwives and consultants on the shop floor was that it was already making things better, and I was quite surprised, because that's relatively quick for our teams to be saying that. We've got quite a lot of experience of this sort of change now, and whilst we've always got to it's making things better, I thought this was surprisingly quickly. And in, you know, the outpatient midwives, who are not, how to put this delicately in public, Karen, but not a group of people most famously known for innovation and enthusiasm for change, were really very clear, the two that I spoke to, that this had already made things more straightforward for them and was going to be better, enable them to provide better care. There were a few teething problems. I fed those back yesterday to the e-care team, and they were pleased to hear that feedback, and they're just going to increase their early life support again a little bit, just to try and make things better. But overall, I think on the ground, notwithstanding the very important reporting comments already made, things are already benefiting.
Thank you, Nick, and thank you for adding that bit of colour, because we know that it can be quite a stressful time for a department when they first move to e-care. So to have that positive feedback quickly is, as you say, really, really pleasing. So thank you. Sue, was there anything you wanted to add before Karen, thank you very much indeed for coming to board once again. It's always a pleasure seeing you at board.
Just to say thank you to Karen and the team, and just to, we can underestimate the level of work that the Ockenden evidence uploading is going to take. Both Karen and I are on annual leave the week after next, so I am going to chase Tracy today, hopefully, to see if we can get a date for the report, so that we've got opportunity to review it before we go on leave.
That would be really good. And can we, I mean, I am sure you won't sit on the feedback until the next board meeting, because we would like some headlines, please, as soon as you get it.
As soon as we know, we'll let you know.
Yeah.
Thank you very much indeed. We shall look forward to it, hopefully. Thanks very much. Thanks very much.
Thank
you, Karen. Infection prevention and control, please. And Sue?
Yeah. So you'll be familiar with this report, which runs through sort of some of the essential steps we're taking to improve our infection prevention control. We have now undertaken a full gap analysis around the findings that were documented and sent through to us from previous HSE inspections to other organisations and guidance, and you'll see that within the pack. I'm not proposing to go through it in any detail. I'm very happy to take questions. We have recently had one patient in the organisation, as Helen alluded to, who was COVID positive, which immediately enacted our processes, which I'm pleased to say we did which were very positive. All of the contacts have now either been discharged or are within the organisation, but we're outside of the 14-day window, which is really good. I'm really pleased to announce that last Friday we interviewed for a lead infection prevention control nurse. You will know that I have been out to advert a number of times for this role. You'll also know that these individuals are fairly rare. And the COVID pandemic has definitely meant people have been sort of consolidating and thinking about their futures. I'm pleased to say that Amanda Devereux, who is one of our current within the team currently, was successful at interview last Friday, and we'll be working with Amanda over the next 6 months to help her develop into the role. But that's really exciting. So I hope you'll all join me in congratulating Amanda for this success. I wasn't planning on going through anything else in detail unless people want to raise anything.
No, thank you very much indeed. I've just got one question on the recommendation, the wash-up review and capacity. And part of my question was around the fact that I knew we were minus an infection control lead. Are you happy there is this capacity within the team, both to do what they need to do day to day and to undertake that review?
Yes, so we have managed. We haven't been without, although we haven't had a designated, we have had somebody acting into that role, Carolyn Holland, who's done an amazing job leading the team, and we've worked very collaboratively together. So, and we have backfilled her. So we are now currently trying to build some resilience within the team and some growth within the team. And so we'll continue to work on that. But yes, we have, and the wash up will be done once we have completed all of the final RCAs. We are still signing off the sort of the most recent root cause analysis. Once we've done that, we'll have the wash up meeting and get a report from that.
Thank you, Sue. I have one question for you from Rosemary, or one comment. Rosemary?
Thanks, Sheila. Thanks, Sue, for your report. In our recent governors meeting, one of the governors raised the issue of lack of social distancing and overcrowding in the admission reception area. What steps you've taken to address that, please, Sue?
So I just need to be clear, Rosemary, what do you mean by admission area?
Reception area when you go to A&E, I believe.
Oh, A&E. So we are working with our ED colleagues, Infection Prevention Control, and Kailesh, the Regional Infection Prevention Control nurse, did have a walk around to help advise us on how we can manage potential overcrowding within the ED should that occur. So we're working collaboratively with the teams to look at how we can try and prevent the reduction of social distancing. There will be occasions where we are unable to not socially distance when we do get overcrowded, but what we're doing is working on what mitigations we can put into place to keep those patients as safe as possible. And some of the simple solutions that Kailesh came up with, we have already actioned. So it is on our radar as being a risk. We are working collaboratively with the team. We've taken advice, and we will continue to assess on a daily basis.
Okay, thanks, Sue.
Thank you, Sue. That's really helpful. Thank you. In which case, can I move on to your nurse staffing report, please?
You can, and Dan is here to present that. So I'll hand over to Dan.
Hello there. Thank you, Sheila. Thank you, Susan. Reasonably positive picture this month around our nurse staffing report. You'll see from the paper that I'll take as read. I'll just pick out some highlights to add some colour. Fill rates has remained positive on 90% in all shifts in all areas. As a trust as a whole, there are some hotspots which are within the appendix, and we received assurance from the wards that this is due to below occupancy as opposed to actual fill. Want to highlight a really good initiative that was developed and launched in April, which is the Safe Care module. There's an example of some screenshots from the paper around what that is. Basically, this is our daily risk assessment of our nurse staffing against actual need. So often external regulators will commend organisations for having good establishment reviews, but often they'll question, how do you know that the staff on for that day are meeting the needs of the patient on that day? And what this does is that gives us this insight. So it risk assesses each of our individual areas, and we meet with the matron team every morning to go over those risks and to inquire what will be done about those risks that remain high, and how we mitigate and how we address that. So it's I want to commend the nursing team for how well they've embraced this, which has been really positive to see, and we're seeing on the daily 100% of our wards entering this data into the e-care system to give us a real good understanding of what's going on a daily basis. Vacancy rates, as you will see from the paper, have had a bit of an increase this month. That was expected and planned for, following the introduction of the uplift from our establishment review in October. That's outside of the establishment review. There has also been an uplift within ED due to the increase of their footprint, which has also driven vacancy rates up a little higher. There in the appendix, you'll see areas of concern, which are over 15%, if you like, vacancies. Biggest worry, I'd say, is F6 and ED, given their new vacancies in establishments. But again, at our check and challenge meetings, we are working with those teams to provide innovative solutions to support them while they're waiting for their recruitment to commence. You'll probably pick out that F6 has got quite a high vacancy rates. Meeting with those teams, they've already recruited into all of those positions. It's just a time frame of waiting for those staff to join the trust, whether that's through HR recruitment or whether that is through completion of nursing degrees, and will land in September. One of the board requests last month was to review turnover rates, which we've done, and the detail is within the paper. Not surprisingly, turnover, while still favourable and under 10%, which is the trust ambition, is higher within the nursing assistant group. And I think we alluded to this in previous months, that this is often a case when you cast the net wide and increase your recruitment within this area. However, we've got two posts within our organisation now, nursing assistants that have taken on a pastoral role, which will be supporting new starters to complete the care certificate, to give them some robust clinical induction, and also some pastoral support, which has been really well received so far. And our turnover rates within nursing assistants will be a measure of how successful those roles are. We've only got funding for the first 6 months through NHSI, but if it is proved to be successful, that's something we want to consider for a long term. And again, on nursing assistants, it was the NHSI's ambition that all trusts were aiming for a 0% vacancy rate for nursing assistants by the end of March 2021, and we were praised and received notification that we did achieve that by the end of March. But unfortunately, that is a moment in time, and as I did refer to, our vacancies did increase in April, but again, that was due to our increase of establishments and the uplift, which I thank the board for. And finally, just again, nursing sensitive indicators, in particularly pressure ulcers and falls, have improved again on month, and again, suggesting that correlation with increasing fill rates and filling our shifts has a direct impact on our patient safety. And I'll take any questions.
Thank you, Daniel. Thank you very much indeed. And there's some good news in there. Rosemary, was that a legacy hand or fresh one? I'll take that as legacy. Angus.
Dan, I'm really loving the science of this report now, because I think it really shows the data that we're using to keep the organisation safe.
Yeah.
Keeping the organisation safe also includes some art, in the sense of the culture across the nursing community. And I wondered if you wanted to just comment a bit on how you feel that's moving forward as well.
Whew, that's a $1 million question. I think I've been in the trust nearly a year now, and obviously when you come to a new organisation you do reflect on the culture that you're joining, and I was super impressed with the nursing teams here in their level of engagement, and that was reflected on previous patient staff survey reports, and I've certainly experienced that here, and I think that's still continues from a culture point of view. The nursing teams are really engaged and want to do more and want to do better, improve the quality of care they provide, even down to the Safe Care module, which I rolled out in April with the teams. I've rolled that out in other organisations and it was a real struggle, and I am pleasantly surprised, well actually I'm pleasantly ecstatic, to be honest, about how well this team has embedded it, because we are less than 4 weeks in and I've got 100% compliance on a number of different days around them inputting that data to demonstrate the acuity within their wards, which, I mean, I know it's not down to me, I know it's down to the teams. So I think there's a positive move to do things better, and again, if you look at the quality improvement initiatives that we're now starting to see pop up on all the wards, I think that is now starting to go throughout all of our organisations. I mean, certainly walking around on Nurses Day with Sue, we were really humbled by the pride that the nursing teams have in their wards, and some of the displays and initiatives they had on Nurses Day to celebrate their teams was just really humbling. So I have nothing but positive to say. I always like to see the positive anyway. There's still obviously work to be done around empowering our staff more, and to really take that initiative to create improvement within their own areas. And a paper that I'm sure will come to the board in the future is the ward accreditation programme that has kicked off in the last month, and that's currently we've got a steering group going through at the moment about what does good look like, and what does good feel like, and how do we measure that, how do we acknowledge that, and how do we reward our staff for that. So I look forward to presenting a paper to you as soon as we have a project plan and timeline and kind of scope for you to hold me account to.
Thank you, Dan. That's really reassuring. Thank you.
Thank you, Dan. Louisa, and then Rosemary, and then I'm going to draw this together.
Thanks, Sheila. Dan, given all the work that we've heard about that's going on in maternity around Ockenden and e-care and all that, and I know you're expecting the new deputy head of midwifery to start and to initiate the sort of staffing review there. We've sort of had a sort of date, I think it's item 1933 on the matters arising, saying that will be started around June. Is that, given all the work that is expected of staff in terms of, as I've said, Ockenden and the CQC, is that a realistic time frame? And if the start is realistic, when can we expect as a board to see the outcome of that maternity staffing review? Because as we've all said, we need to get, maternity in the right place.
Are you referring to the neonatal review that's in the actions?
Yeah.
What we have within the neonatal area is a similar acuity and dependency tool that I'm not super familiar with, called Badger, and that does a similar thing to what Safe Care does in regards to predicting their acuity. So we have data available to do that piece of work. And I'm keen to work with that member of staff when they start. But it'd be unfair for me to say, Louisa, that things have started right now. But as soon as that person's in post, we can progress that. Neonatal staffing is not something I'm super articulate in, so I'll need to be led by those that work within the department to provide that level of nuance.
Okay, thank you, Dan. Louisa, does that cover your question?
Yeah, I think something that I'm just going to sort of, hold in the memory banks and come back to. But yeah, thank you.
Thank you, Louisa. Rosemary?
Thanks, Sheila. Thanks, Dan, for an excellent report. I've got a practical question, actually. Given all the nurses that are joining the trust now and what have you, is there sufficient accommodation and training support and all that kind of backup to cope with the influx of nurses coming in?
We have a fabulous education team here, and we do have the right number of people in the building to provide that level of education and training. What has challenged us over the last few months is the accommodation of training. So, for example, we have our pipeline of overseas nurses is 5 a month, which is we're just currently scoping to see if we need to do more of that or take more in every month, given our increase in establishments. But we are limited to how many people we can have in a training room at once. And obviously, if we take a bigger cohort and split that training out, that does impact on the resource. So the education team are actually putting a piece of work together for a bit of an options appraisal about how we can achieve that within the current restraints. But I think the introduction of the NA pastoral support has really been well received. So the numbers of NAs we've got coming through should hopefully be just as supported. So I don't have too many concerns around our ability to provide education, but the concerns are restrained, if you like, by our
accommodation,
our IPC and classroom sizes. Yeah.
Okay.
And likely to be an issue ongoing, I suspect. So trying to find solutions for it will be an ongoing issue. Dan, thank you for your report. As ever, it really does help to give us some assurance around where we are in terms of the nursing cohort. And thank you for your answer to Angus, which gave us a more qualitative take on it, not just the numbers. So thank you for that. I'm going to move on now then, please, to the quality and learning report. Sue, do you want to kick off?
Yes, thank you, Sheila. So obviously the report is quite robust. It's got a lot of information within it. I don't propose to go through the details of the SIs that were reported in Q3. What I would like to do is just to highlight the sort of ongoing work we're doing around the patient safety incident response framework and how this is starting to mature and take shape for us as an organisation. We have, as you know, identified our themes for analysis. We have now been running for over a month our emerging incident review meetings, which is where we see potential incidents coming on a weekly basis. It's proved so popular, or not as the case may be, that we're now going to have to extend it to 2 meetings a week to be able to make sure that we give each incident the required amount of time for discussion and then allocation to agreed pathway. I think it's important to note that each incident does get considered within its own context, even if it is going down an agreed pathway. So, you know, each patient fall does get reviewed in its in its entirety during the emerging incident review. What we don't do is do an individual root cause analysis. It will go down the falls improvement work that Helen is leading. At these meetings, we do discuss the rather than duty of candour, we've started to call it being open, so that we can ensure that we have clarified that where things haven't gone according to plan, we have both had verbal and we then follow that up with written documentation to the patient or their families or carers. I'm happy to take questions on this at the end of the paper. Following on from that, there's been a thematic report regarding mental health. You'll be aware that there's an awful lot of published information in the press at the moment around how we manage our patients with mental health, and acknowledging that mental health is an illness in itself. We shouldn't just be focusing on the physical health needs. We should be focusing on our service users' mental health needs as well. You will be aware that in January last year, Natalie Bailey was appointed as the head of mental health for the organisation, but then the pandemic overtook and we had a reshuffle in the nursing teams. And so Natalie filled in for head of nursing for medicine for probably approximately almost a year actually. With the arrival of Sandra as head of nursing for medicine, Natalie was then able to be released to do the role that we originally appointed her to do. And I think everyone that has met Natalie or knows what she's doing will acknowledge that she is doing an amazing job for this organisation and the Alliance and the ICS. Her mental health knowledge and expertise is absolutely second to none, and she's worked tirelessly with our colleagues through NSFT and the Alliance to really build the mental health agenda for us within the acute and the community. So that's really good. And then the learning from deaths continues, and this is something that Erica, for example, from the Learning from Deaths team, presented yesterday at our Nursing Midwifery Clinical Council to raise the profile of the Learning from Deaths work, and also the fact that we are learning all the time from all of our patients' experiences and times with us in the organisation. I'm happy to take any questions.
Thank you very much indeed. So it's a fairly comprehensive report, but fairly self-explanatory, but I'm happy to take any questions from colleagues. David?
Yeah, just a comment really. Actually, given the importance of mental health and well-being, particularly after COVID, it would be quite interesting maybe if Natalie could come to board at some point and actually give us a little bit more detail about the work that we're doing around mental health, both within the Trust and the Alliance.
Absolutely. She would be thrilled to come.
And actually, David, I've just scribbled it on the agenda before you said it. I think it would be a very good thing, I think, because I know that colleagues will not necessarily have met Natalie. And I think this is not just an important issue now. It's going to be an issue there's going to be more issues around mental health, I think, moving forward during and post-COVID. So thank you for that, David. Good suggestion. Rosie?
Thanks, Sheila. Thanks, Sue. Under the patient safety investigation, there was an event where a patient had to be readmitted because of inadequate medicine management. And I remember that in the CQC report, there was a comment about our inconsistent medicine management. Can you just give some assurance that this wasn't the same issue and that the necessary steps have been taken around that?
So my understanding around the CQC report on medications management, Rosemary, was very much about how we store and we check our medication processes. So this was not in relation to that, no.
Okay, thank you.
And we are looking at patient discharge as one of our themes going forward. Sheila, I'd just like to say that we are, as you know, our quality walkabouts have been restricted or if not non-existent during COVID with our partners, if you like, and myself and the senior nursing team are looking alongside with Joe Allen from the CCG of how we can start to reintroduce some form of a quality assurance walk around. What we want to do is use it as more as an opportunity to experience the feeling on the wards rather than a quality assurance visit as such, because we have a lot of those and we have a lot of audits. So if you can bear with us, what I'd like to do is set up a sort of focus group on how we can do that, and I will absolutely be requesting some support from the governors and the NEDs on that so that we can have all the right people around the table to make something.
That's brilliant, Sue, because it's something I know my non-exec colleagues and governor colleagues have felt the lack of very keenly. So yeah, we'd have enormous enthusiasm about being involved.
Okay. Great
news. Thank you. That's a really positive note in which to close on that section of the report. Thank you very much indeed, Sue, for all you're doing, and thank you to your teams, and particularly to Karen, who comes and experiences board monthly. So thank you all. Can we move on then, please, to Future Systems Board Report? And Craig, over to you.
Thank you. So you've got details in the paper of the work that we've undertaken over the last month. Some of the key things to pull out are the engagement process around the environmental impact assessment that started, and we've had a couple of sessions with members of the public and in particular local residents around that process. The digital fortnight concluded within the last month, which was an initiative where we took people out of their normal role for a fortnight to focus on the digital footprint that we will have within the Future System programme. This was contributed to by a number of external partners and we were helped with the facilitation by a company called Atos, who are working with the Department of Health on the new hospitals programme. And the feedback from Atos in particular was that the work we're doing is constituting a national exemplar around planning for new technology within the future system, or within the new hospitals programme. We have sought to the Department of Health because it is clear that within the new hospitals programme, they want to develop a blueprint for the use of technology within all of the 40 hospitals, so that they're not repeating the work 40 times. And I think that we've got something that we can contribute nationally to that programme. So we're talking to the Department of Health around that. You've got a photo in the paper of some of the work that we're doing around G10. Again, there's a lot of talk about modern methods of construction. It's worth noting that over the bank holiday weekend at the beginning of May, there were 92 units that were transported to and installed on site, and you can see the progress detailed in the paper. This was the first time we've done this. These were all units that were constructed off-site and then delivered and installed on site over that weekend. So a huge amount of work. And it's worth noting there is a degree of disruption that does occur to the within the local community when we do something like this. We did seek to minimise disruption to ensure that, for example, reversing indicators were turned off during the night, so that we minimised some of the disturbances to local residents. We did inform local residents about what was going on, but we're very grateful for their forbearance during that process. The only other thing I wanted to pick up on was the question that was asked around engagement. One of our governors asked the question. It's worth saying we are in a different position to King's Lynn. King's Lynn obviously face some of the same structural issues we have, and as an organisation, we're fully supportive of their attempt to become one of the hospitals in the new hospital programme. In terms of our level of engagement, we have got some formal engagement that we have to undertake, and that's included in the paper. So as part of the planning process, we've got engagement planned during June, July, and then later on in the autumn. But our approach to engagement goes much further than the statutory requirement. We genuinely want governor and public involvement in designing the clinical pathways, designing the way in which a new facility will work to improve the quality of care that we provide to the population. So the engagement we have is maybe more subtle, but I hope it's much more meaningful than trying to lobby for a political change. I'm sure we won't get it right, and what we do need to do is ensure that we listen during the process and respond accordingly. It's genuinely a desire to hear as many voices as possible as we design what the new system looks like, because that will only make for an improved outcome. Wasn't anything else I wanted to pick out in particular, but happy to answer any questions.
Thank you very much indeed, Craig. And can I just comment on the decant unit? Having been in it, it's amazing. It doesn't feel like a prefab type building. I mean, all right, it does at the moment because it's still being put together, but you know, it has none of that bouncy feel, shall we say, to many of the buildings I've been in the past, which have been constructed by similar methods. David.
Yeah, Craig, there's been some great work, co-produced work done on designing the new system and what I would call like a bespoke approach. Are we concerned in any way that the National Hospital Programme might bring a more centralised focus to new builds, which might impact on our plans and all the things that go with that, whether it's planning and architects' designs and everything else?
So are we concerned? Yes. I think that it should be okay. So that the plans are to develop a standardized approach to some of the units within any development that should be repeatable. So things like wards or single rooms or outpatient rooms or theatres, there's a degree to which every hospital does not need to go through a process of independently designing those. The way in which they will be put together should be a reflection of both the environment in which a new facility is being built and the clinical model that is being developed. So I would hope, and we as a team hope, that there will be the flexibility to both learn from other organisations, but also implement that learning in a way that reflects the really good work that's being done on the clinical pathway development. So yeah, we're alive to the issue, and you're right to highlight it. I hope that it won't be so prescriptive that it impacts adversely on the clinical model.
I think there's some particular challenges to come in that area. Craig, thank you very, very much for that report. I particularly like the allusion to us being a national exemplar. That's a very nice place to be. And I think the amount of influence, we may not have placards on roundabouts, but I think the degree of influence that you and Steve and the team and Gary are exerting at national level is very considerable, and is, from what we can see at the moment, is very much aimed in the right place in the right way. And I think that sometimes quiet diplomacy can achieve as much as waving placards. So thank you for that. And I will move on to the governance report. Pretty self-explanatory. Sue, did you want to make any comments?
No, only to sort of give Richard's apologies for not being here, but as you say, the report is fairly self-explanatory.
Is there anything anybody wish to pick up from that? Or are you happy to take that as read? I'll take that as read then. Thank you very much indeed. I don't have any other items of other business, other than I have asked Nick to do a very brief looking forwards kind of state of the nation, challenges ahead, with his medical director hat on as he hands over to Paul. So this is the point at which he passes a rather slippery rugby ball to Paul. Nick, this is your opportunity. And I think actually, if I may say, I think it would be good if we had a clearer slot on the board always for the medical director to articulate some of those clinical challenges as we move ahead. I think it is something we should have instigated before now. But Nick, I give you the floor. Has he sneaked off for an early lunch?
I think Nick's having some connectivity problems, if I'm honest.
He was. So he did.
He's here.
He heard your introduction, Sheila, but I think he is back now.
Nick,
you're on mute, Nick.
Still on mute.
Nick, I'm going to hang on every word you come out with here, so.
No, still on mute.
Okay.
I think you're with us.
Right, sorry, can you hear me?
Yes.
So sorry, Sheila, I missed whatever I gather it's me, but I presume
it is you, and it's the email.
Relates your email up from that I read this morning. Right, thank you. Sorry, the computer broke and I had to come out and back in. Thank you. So a sort of state of the nation was what you asked me for from a clinical perspective, and I think that generally things are good. I see a lot of pride in their work and care for our patients in the medical teams, and good teamwork. over the last couple of weeks, there's been an interesting trend in the region of a real flurry of never events, felt to be in relation to people getting going again, working in slightly different ways with slightly different practices and a bit more stress. And I'm pleased. Normally I wouldn't say this because it's tempting fate, but it'll be Paul's problem, not mine. So I'm pleased that that hasn't happened. That hasn't happened to us. And I think that is because of the care and attention that our teams give. Some of the work that we've started is definitely not finished. Some of the engagement work, and particularly so for an example, the support in stressful times work. But that's work that Paul was leading on, and so I know it won't get lost, and I know it will continue. I think we've got the best ever group of clinical directors that we've had. I think that they really are now universally of good quality and will be an asset to us. And I think there's a real opportunity for progress now under Paul's stewardship. It is difficult to balance the demands of recovery and the increase in emergency work and so on, and there are definitely tensions that arise as that goes on, and the remedial building work, of course, whilst essential, doesn't make any of that any easier. And so I think it's important to recognise the stress that our teams face. But we've had some really good progress. We've recruited in some very difficult to recruit to specialties, plastic surgery, chest medicine, in the last few months, and we've also got some really good candidates for a microbiology recruitment process coming up. There remain some challenges. Urology, histopathology, anaesthetics are definitely all challenges, and I think we'll see how they go. There is, for the first time in my tenure, an enthusiasm, or at least a willingness widespread in the organisation to collaborate more, and not just with Addenbrooke's, but also with ESNEFT. And the need to do that has been highlighted and is being focused on. I think teams are engaging with the future system work, both in the hospital and with primary care. And I think Helena's doing a great job of leading that. So I don't think I could be leaving you in better hands than Paul's. And I think that things will be better very shortly.
Thank you very much indeed, Nick. And at that point, I'm going to give you an overall thanks, because I think you've made a huge contribution to the staff, to the trust, to patients, most importantly. And I do thank you for that. And the fact you have always been a consummate professional, whether it's at the board or on the floor or, wherever you go. And you leave on a real high from the vaccination point of view. I mean, the vaccination programme was exemplary. And I mean, I think all of us have experienced that, if you don't mind me saying, the sharp end of it. And it was a superb programme. And I think, you can be very proud for yourself, but I mean, as a trust, we're very proud of what we've achieved there. But what I will miss enormously, Nick, in your departure is the sense of humour, your dry allusions. The phrase mothership will stay with me forever, or at least for my time in the NHS. That phrase will be much used, I am sure, by the board. And I think it's been a year in which there's not been enough humour, as Angus, who is also departing, has commented. We haven't had the human interaction and the ability to interact with each other in that human way. So I'm really sorry, Nick. I would have liked us all to have been in the same room where we said goodbye, but I know that we will have a more informal opportunity to do that. Because you aren't really departing, though I hope not to see you in your professional role. I know that we will be seeing quite a lot of you around the trust, and your wisdom and your brain will not be departing. So it will be good to know that you are there. So thank you, Nick. Thank you from all your board colleagues and wider, because I know that the governors who are still in the room will equally share my thanks to you. So thank you. And I cannot let this moment pass without saying goodbye to somebody else. And it's my turn to embarrass Angus now slightly. Angus, you've been a superb non-executive director and a very safe pair of hands as audit chair, and I'm immensely grateful for that. You have always given your colleagues a great sense of confidence in the grip you've had on the governance agenda and on the risk agenda. You're always measured and thoughtful, but you're always robust in your challenge. You smile while you're doing it, but you are robust, very. But you also bring a human compassion and that touch of humour as well. And it was you who said about we needed more laughter. And I think you're absolutely right, and I shall remember that. I think you have given great support to your colleagues, from whether they were executive, non-executive governors, and we've all felt very supported. We've all felt very supported by you. I, for one, thank you, because I've learned a lot from working with you. So thank you, Angus. And it's always sad to see people go. We wish you all the very best for that, and Angus. So thank you. Steve, I think you want to say something as well.
I just wanted to sort of echo what you've said. Nick is stepping down, but he's not leaving the organisation, and we're extremely grateful that we'll still be able to, hopefully, Nick, rely on your expertise in the organisation, and so we want to thank you for that. A big thank you for all you've done leading our medical teams through the pandemic, for all you've done around the vaccination programme. You've brought pathology home. You've helped us modernise the way that we do job planning in the trust. You've been a passionate advocate for new technology through Medic Bleep and Doctor Doctor and M-Modal, and making sure that the business cases around e-care are properly safe when we implement those, and please don't underestimate the amount of work that goes into that. We had a real focus on learning from deaths. You've championed public health and population health. You've been our maternity safety champion, and you've brought together, I think, a very, very strong clinical director group, and I've really enjoyed working with you, recruiting some brilliant, fantastic new consultants that will underpin both the quality and the service that we give to our patients for the foreseeable future. So you leave a great legacy. It's not an easy job, and we've been working through turbulent times, but you've always done it with great humour and great professionalism. So thank you, Nick. And Angus, the best NEDs are both high challenge, high support. You do exemplify that. We hang on your every word when you make a contribution. They're always incredibly thoughtful, but also supportive, and wish you well. And it's a real pleasure to work with both of you around this board table, trying to do our very best for local people, which you're absolutely committed, and that's shone through. Thanks, Sheila.
Thank you, Steve. Did either of you wish to say anything else, or are you going to save your words for other occasions?
Sheila, I'll just say a couple of things. I mean, I should say thank you. It's very kind words indeed. As you know, and for a number of, as I've said to a number of you, I think it's the right thing for me and the trust that I move on now. A couple of passing thoughts. The first was, please, please, please own your own future, because I think this is a fantastic organisation and it's got the strength to do that. So please do that. The other thing I would say is that there's a danger when we sit around this table that we hear all the things that aren't going quite so well, but never lose sight of the fact that for somebody like me, it's humbling to sit in the presence of what you do for the patients, for the community, and for the staff of this organisation, and indeed the wider NHS. It is really magnificent, and don't ever forget that.
Thank you, Angus. And Nick, was there anything you wanted to add?
I think I've probably said enough, Sheila. Thank you, but it's been a pleasure being part of this board. I've really enjoyed it, and nothing more fitting than to leave with Angus. So that's nice.
And we will have the opportunity to say farewell to you properly and more informally. So thank you. If then I could move on to the date of the next meeting. I mean, I think we're all aware that we're in a state of transition with a change in committee structure and board structure, or board meetings timing structure. However, in Richard's absence, it's very clear, and also looking at people's commitments diaries and how we schedule this, that we need to maintain the two existing meetings in the June and July meetings. So we will adhere to the June and July dates as they were, which means that we will meet again on the 25th of June, as we would have done under the old schedule. We will then do a further piece of work to make sure that we can get diaries properly aligned as we move forward. It's important we do this. We've talked about the 3I committees, and it's really important that the whole information flow fits with both committee work and with the board. We've already had a number of occasions where we've had to give a little bit of a government health warning around data. And while it'll never be perfect because of reporting times and lags, we do need to get as close to it as we can, because that means that the board is dealing with the most meaningful information that it can. So 25th of June, next meeting for your diaries. Can I thank you all for attending? We are running slightly late, having done better this morning than usual. So can I suggest we reconvene at 25 past, which will give you the 15-minute break you would have normally had. Is everybody happy with that? I see no objection, so I'm afraid you only get 15-minute break. And so I will see those of the board who are attending the private meeting back at that point. So thank you all very much indeed. Thank you for attending. Thank you, Angus. Thank you, Nick. And I'll see you back at 25 past.